is my pleasure. First of all, last one of the semester, the new semester, the spring semester schedule will be coming out soon, at least the dates on those. If anyone has suggestions of additional speakers you would like to have, please let me know, and I'll do my best to arrange for that. It's my pleasure. We save the best till last. Is that right?
No.
This is Dr. Pat Kitzman, who is a PhD and also a PT. Let's see, he did his BS in Biology and Business Administration from the University of Wisconsin-La Crosse. Then a Master's of Science at University of Wisconsin-Milwaukee. And he did his PhD at Ohio State, which we'll kind of, ignore at least for now. He did a postdoctoral fellowship here at UK and has been a faculty member ever since then, and is now an associate professor in health sciences. And I think Pat, in his presentation, is going to certainly talk about the research and science that he currently does, but I think he's also going to maybe talk a little bit about his evolution. He described himself not to me as a lab rat, but a lab mole at one point. But as you can see from his title, he does a lot of community-based research now. So, incorporating a little bit of, how he came to be at the place he is in his life right now. Okay? Without further ado.
Thank you, Jody, and thank you very much. As Jody had said, I'm going to talk a little bit about how I evolved a little bit, because students, I haven't worked with students for quite a while, when you start to get into a research track, you think, oh, this is my entire life and I have to do this until I die. And I am proof that you get to evolve, you get to change with your interest. And in some ways, you almost have to evolve and take things to its logical conclusion. So we'll talk a little bit about how did I become, I was a nerd. I mean, proud of it, but if you watch Big Bang, I was more Leonard than Sheldon. I never made it to the Sheldon phase. Thankfully, my cousin is Sheldon, so he doesn't get to Big Bang Theory. And then we're going to talk a little bit about the evolution of our community-based network, which has been just exploding for the last 4 years now. And trying to work within the community, is the ultimate reach of your research. We can do everything in a laboratory, we can do things in that first step of translational bench to bedside, but can you get it to work in the real world? And the real world is very muddy and very hard to work with, so how have we gone about trying to do it, especially with populations that are really tough, which have the kind of the difficult neurologic conditions, stroke, TBI, spinal cord injury. So, as Jody says, I am native of Wisconsin. I actually was born in Milwaukee, but I grew up in a tiny town in northern Wisconsin called Rhinelander. And it's very rural, which actually, that little point there has done more to help me in the last 3 years than all of the letters behind my name. And I'll tell you why, because that little concept helps me get out in rural communities. Because I can talk to people about, yeah, I know what you're thinking in many ways because been there, done that. At 8,000 people, Rhinelander was the thriving metropolitan area. We were the big city that everyone else came to. So, and like she said, I did my bachelor's at UW-La Crosse, and I think the one thing I love about that is I was told I would never ever make it in graduate school. Never apply. I'll never get a degree. So I used that to motivate me to do everything else that I do. And I actually came here just to do a 2-year postdoctoral fellowship in molecular neurobiology. And I did it actually right across the street, worked with then Kathy Elbers and Brian Davis, who are no longer here. So I went molecular, I was gene splicing, transgenic mice, all the true geek out stuff. So, yes, I was a true lab nerd. Then, I went to PT school here also. Here's where I became a physical therapist, and they across the street, didn't say they gave me a personality transplant. Allowed me to talk with human beings there. So I graduated from the program here, and for about the first 8 years, I had a wet lab over in College of Health Sciences, And before that, we were in about 3 different buildings. So I did a lot of work, and I still do a lot of collaborations on secondary complications following spinal cord injury. Spinal cord injury is bad, but it's now the rest of their life that they have to deal with infections and pressure sores and autonomic dysreflexia. How do we take care of someone who is now going to live 30, 40, 50 years with their condition? And how do we do better pharmacology with them? So I have a lot of collaborations with Dr. Sasha Radchevsky over in Scobert group there. But I got tired of doing stuff strictly off the bench. He's like, how do I get out into the community and impact actual human beings? So we, since about 2008, have had the Karen Project, or Karen Project, depending on how you want to pronounce it. I slip into the Karen Project because my wife is Karen, so it's easy for me. But we started to develop what we call the Kentucky Appalachian Rural Rehab Network. Okay? And everything begins with a simple question. Boy, were we naive when we asked this question. The good thing about being so naive is you're not smart enough to realize that you shouldn't be able to pull it off. So we didn't take no for an answer. So what was our question? Our question was, when I rehab somebody, and I did a lot of work in acute rehab, so I did my PT over at Cardinal Hill. I also have done a lot of home health and work in skilled nursing facilities as a PT, my side job to actually being a faculty member. When I rehab someone at Cardinal Hill, I've got 2 months, and that time is shrinking and shrinking and shrinking, the amount of time I have to work with someone who has a spinal cord injury. When I send them back home, how are they doing? That was a question we couldn't answer. It's like, are they getting back to life? Are they reintegrating in their community? Because me as a PT, that is my ultimate goal. I do not want to have someone who is wheeled into their house and that's where they sit. I despise that. So, what is their quality of life? How can we reduce the number of times they have to come back to the hospital? Spinal cord injury is a small population as a whole, but they have some of the highest reoccurrence rates of going back to the hospital. So from the healthcare point of view, huge healthcare costs, but many of these individuals are my friends. And the amount of time they have to spend at home in bed because of pressure sores and different infections directly impacts their quality of life. Okay, so how do we reduce that? And if you're going to set your goals high, let's go for it. How do we improve the healthcare system? And that's what we're trying to tackle right now. Kind of go with the go big or go home mentality here. So how do we improve health, health care, and quality of life? So our initial study was, okay, what are the supports and barriers to long-term health for someone who's going back to a rural community? Rural. Rural changes the whole ballgame. You have all the resources you could want in a big city. So we thought there's a lot of complications for people who live in the big city. At the moment you get them past Fayette County, Jefferson County, the game changes. So what are the supports? What are the barriers to me getting long-term health for these individuals? And we wanted to look at the point of view of the client, their caregiver, but also the healthcare providers, because guess what? The healthcare system has its own constraints on them. There's certain things they can't do, and it drives them nuts. And this was a study that I did with a great friend of mine and collaborator, Dr. Beth Hunter, who is the Director for Research over at Cardinal Hill. Okay, one of the things we found was a strong need for connection for the spinal cord population. They just don't talk to each other. It's a weird population. You have other groups, like the MS group, or the group with cerebral palsy, or some of the stroke, where the people have lots of big support groups and they talk with each other. The spinal cord injury population is very, very different working with us. And they wanted to be able to connect with each other and service providers. Okay? Peer mentoring is what we wanted to start to get into. But limited resources. Transportation is huge in the rural community. If you can't get to the hospital, if you can't get to your rehab, then you're not going to get it. And different resources for adapting homes and maintaining appropriate equipment. You break down your wheelchair out in Pike County, guess what? It's going to take a long time to get the vendor in from Lexington or Louisville to fix it. So we got a couple of projects to bypass that system going on. We're very good at bypassing is what our whole group is about. From the healthcare side, more and more of the rural doctors, they are great generalists. I can't imagine how much information they have to know, from sniffles to black lung to everything else going on here, that they felt very, very uncomfortable working with someone with neurologic conditions. And we have stories of one of the members of our group broke his leg on an ATV, because yes, they still use ATVs even after a spinal cord injury, broke his leg, got himself to his truck, got himself to the hospital out in one of our rural communities, and they were afraid to lift him up to take an x-ray. So they put him back into his truck and made him drive to Lexington, which was a 2-hour drive. It happens a lot more than you think. So part of what we've been doing for the last 3 years is a lot of education of healthcare providers about, okay, here are the special needs that you're going to find with people with neuro conditions, and bumping up their skill sets in that. And advocacy. The people, since they're not connected, don't have a voice. And this is one of our current projects that I'm going to tell you about that should be hopefully a fun game changer that's going to happen next year. Okay. We've talked about barriers, but the one thing that people never concentrate on, and Nancy Schoenberg's group is wonderful at doing this, is there are an awful lot of assets in a community that you can tap into if you can find them. Small town mentality. I come from a small town, as we take care of our own. We will help our own. We will do what it needs. So if you can tap into that, that's good. There's a lot of local community action groups that exist only in a town or in a county. If you can find those officials and tap into them, they are a great resource. That's part of what we've been doing, and we've done that pretty successfully. Finding an awful lot of regional organizations that keep saying, well, we're the best kept secret in Kentucky. I go, well, that's great, but not good. If you're a secret, you're not being used to your potential. So how do we tap into these best kept secrets? A lot of people like the lifestyle of being out in a rural community, and actually there's a lot of data coming out with people with traumatic brain injury. They actually prefer rural communities because it helps them maintain their environment, so they don't have so much noise going on. It's a safer environment for them. So for some areas, it's actually very, very welcoming. And they generally love the region here. So our group is, how do we decrease barriers and increase the supports? Small task, right? Once again, go big or go home. If you're gonna do it, go for it. So what was our suggestion? Let's build an entire organization. Actually, we never set out to create ourselves. We met at the Center for Excellence in Rural Health in Hazard, Kentucky on May 21st, 2009. Remember the date well, because that's when we came into being. And we had 27 individuals in the room representing 15 different organizations, plus, and here's your kicker, if you're going to work in rural communities and you're going to work with a population, that population better be involved with it. So we had individuals with spinal cord injury, their caregivers, and members who have had stroke in the same room talking with us. They know what they need. Okay. And we also had the privilege of having a wonderful lady who is the executive director of the Arkansas Spinal Cord Commission, Cheryl Vines. Came in all the way from Arkansas to talk to us, and I was actually contacting her yesterday about one of our big initiatives, and she's all fired up about it. So when we set up after that meeting, we go, okay, let's pool all of our resources, and we'll help another group. And the group we wanted to help initially was the Spinal Cord Injury Association of Kentucky, SCIAC. Until we found out SCIAC was essentially a website. They didn't do anything. We never did get anyone to contact us. So we go, all right, what's our next step? So we were finding these groups where we're going, okay, you're doing great work, we'll partner with you. What do you need us to do to help you out? Well, that worked for about the first 6 months, and then somewhere it switched. And now we have the groups calling us saying, okay, how do we partner with you guys? We've become the hub that a lot of groups are working through. We've become the linking partner. Okay, you're going to hear two terms, usually when you're talking about community-based research. And it's boring, because we don't believe in the rules anyways, but I'm there to tell you some of the rules. You're going to hear practice-based research networks, and I know Carl Medicola and Jennifer are putting one together. And there's several of them on this campus, and a community-based participatory network. A practice-based research network, kind of at its core, is kind of disciplinary. So it is the public health people, or Kevin Pierce has got one that is the Kentucky Ambulatory Network, which is primary care physicians. Dentistry's got a marvelous one, but it's dentists. So it's one particular discipline trying to solve some problems, and they're doing some great work. We're a little closer to a community-based participatory network because we are everybody. We're the rest of the story. Being a lab geek and having to survive my postdoc years, I will beg, borrow, and steal anything I can get my hands on. That's how you survive graduate school. Being a PT, rehab therapist, I will beg, borrow, and steal whatever I need to help my client. So it was ingrained into me that we had to be multidisciplinary. I mean, big time multidisciplinary. So community-based participatory network means you get the community involved with you. And trust me, if the community doesn't buy into what you're going to do, you will fail immediately. End of story. I've seen it happen over and over again in talking with community members who say, you have researched us to death and we've gotten nothing out of it. That's your mindset going into meeting with these people because that's what they think. So you might get someone to buy into a research project out in Harlan County and that, but it's going to be a one and done for you unless you give back. So we kind of took some of the principles of a community-based network and then we wrote our own rules because quite frankly, why do we have to follow everyone else's rules? We are who we are. We are a very unique entity. So you want to have a clear purpose when you do a community work. Okay? You have to become knowledgeable of a community. The moment you step in saying, I know more than you, you might as well walk out. Because guess what? You could have all letters behind your name, but you don't know more than what's going on in that community. You don't. And if I'm going to go in and tell someone with a spinal cord injury, I know more than they do, and I don't have a spinal cord injury, that looks pretty stupid. So show basic common courtesy. I don't know how many times I have not seen that thing. The stuff they touch in kindergarten. Share your toys. Be polite. It's amazing how much that works. We are proof. We have exploded. 3 years we have pulled off some fantastic stuff. And it's all because we respect all of our community partners and we try to be nice. We play well with others. Okay. I don't think I can stress that the community has to buy in. And I can tell you from a research point of view and from a funding point of view, this is the key topic now. NIH is funding this. In fact, we're in year 3 of a very large 3-year grant specifically to do this. And a whole new organization called the Patient-Centered Outcome Research Institute, or CORI, got funded by the national government specifically to how do you engage the community. Because we think we know what they need is best for them, but if we don't ask them, maybe it's not. From a clinical point of view, we have to have clinically measured outcomes, but they have to also be patient-centered. If I'm going to rehab somebody's shoulder, I better ask them why did they need it rehab, what do you want to get back to? If I'm going to rehab somebody's knee, well, sir, if it's a 14-year-old who's trying to get back to sports, that's a whole different mindset than my 68-year-old lady who has had a total knee replacement and just wants to be able to garden again. So that, from a clinical point of view, should make sense, but it's not done. We always think that we need to know. The community must get something out of it. Otherwise, it's a one and done, and you must be accountable to the community. Okay? And you must be sustainable, because in this day and age, we're not going to get any money from the government. And if you're going to try to live and die by the grant, you're going to die. You can ask our faculty members who write lots of grants, and I have written lots and lots and lots of grants. And the funding mechanisms right now are getting just tough. That's our reality that we live in. So how do we sustain ourselves without having to rely on the government? We have found a way. I work with some amazingly creative people. So who are we? We've been talking about it. Strength is in that diversity. We're multiple components of the College of Health Sciences. So we have a lot of people from the RHB program of that. Cardinal Hill Rehab Hospital. The Appalachian Regional Healthcare System, which is 10 hospitals throughout the Appalachian region. We're the Centers for Excellence in Rural Health and Hazard. We're Kentucky Home Place program, which is a lay health navigator system. We're the Kentucky Agri-Ability program. Those guys rock. They work with farmers and they will trick out anything to get you back to work. So we have on our website people transferring from their wheelchair into a skid loader, onto their tractors and that, to get them back to life. And they will do some really amazing stuff to get you back going. State Office of Voc Rehab, Kentucky Home Place, the Scoberg Group. We got adopted about 2 years ago by this gentleman, Lou Gaston from Grip Solutions. He's got a company out of Pennsylvania that just contacted us, says, I'm going to play with you guys. Cool. He and his company have developed some just really awesome new materials that are very non-stick, but they provide grip, they're non-stick, they're easy to clean, and you can turn them into anything you want. And he has a very low-tech approach to making people very, very functional. He's a fun one to work with, and we've got one really cool project I'm going to talk to you about that gave back quality of life to one of our partners. Okay. We are also all of these people. We work at the state level too. The state has contacted us, we work with the state. We work with a couple of components of the Veterans Administration, all through the back channels because the VA is really difficult to work with, so we just bypass them and we work with the clinicians. We just don't ask permission. The Army Wounded Warriors program is one of our new ones. The Kentucky National Guard has got a new medical outreach program, and we've been working with them for well over a year. Cody Stanger has been amazing for that group. Department of Aging and Independent Living, the Brain Injury Alliance of Kentucky. All of these groups are us. But most importantly is we have individuals with spinal cord injury, caregivers, stroke, and now we're adding TBI. They are also us. Everything we do, they have input. In fact, a lot of our original programs and ideas came directly from them. They go, why isn't someone doing this? Well, let's do it. Seeing as I get my hands on all the PT students I can get that I want, because they got to do research projects. And our students have done an amazing number of research projects. And the PT students love it because their stuff doesn't sit on a shelf. All of their materials have either gone on the net. The videos we have just done have been seen by up to 23 countries, some of their videos. And their educational materials have been seen throughout the state and throughout the country. Okay. So what do? We define problems, we develop knowledge resources, and we come up with some solutions, and we disseminate them. Basic. But let's put it in a little different thing. So what do? We're here to educate. Because if you don't educate, everything else falls apart. And we educate both healthcare providers, clients, caregivers, communities. But when I go out in the community, I myself am getting educated every time I go out there. I use my community partners as my teachers. Because I learn more from them than I usually give back to them. Advocacy. We share information, we do research, we got multiple projects I'll tell you about, and we're trying to increase quality of life with participation. Okay, so what are some of the education we've done? And if you go to our website, we've got a bunch of these. We've been developing a whole series of educational videos. How do you do a basic transfer from a wheelchair? Seems basic, we do it all the time. But when you have someone who is at Cardinal Hill, their life has literally been changed. And they're being bombarded with all of this information and training. Their caregivers' lives have also changed. They're being bombarded, and they are getting less and less time to be there. And then we say, okay, go home, be prosperous. How much education do they actually remember? A lot less than you think. Real basic skill sets that they go, oh, I can't remember how to do it. And this is where people get hurt on basic transfers. So the PT students developed a whole series of how do you transfer someone from a wheelchair to a table? How do you transfer someone onto a couch? How, if someone hits the turf, how do I get them back up into a wheelchair? And the thing that we've found over, since we posted those videos and have been talking with them, is a lot of the healthcare providers in some of our long-term care facilities are the ones that want to get this information because they don't get as much training as they should. And they like to have little refreshers. But we also have gone to the real world, and that's the one where we show you how do you get onto a skid loader, how do you get onto a tractor. One of our partners, Bob Patterson, great old-time farmer. I love working with farmers because they just build whatever they want. Built this awesome lift to get his wheelchair up into his fishing boat because all he wanted to do was to fish with his grandkids. This kind of system doesn't exist, so he just built one. We've got that on. How do you get onto an ATV? We've got disclaimers all over that one, but the reality is we've got people who need to work out in the fields. ATVs, how they're going to do it, so how do you do it safely? And we have at least another 8 different videos that are ready to be just kind of finished up. So educational materials. One of the first things we turned out was an educational pamphlet. And it was all of our partners in wheelchairs are going, do you know what, whenever we travel, we call the hotel and we say, are you handicap accessible? And the hotels by law are saying, yes, we are ADA compliant. Great. You can be handicap accessible and still not be wheelchair accessible. To be handicap accessible, you just need a grab bar on there, but if I can't get my wheelchair actually in the door, guess what, I got a problem. So we developed, working with them, handouts, very practical steps. Here are the actual questions to ask when you're traveling, so that you can feel comfortable and want to travel. We want you out doing stuff. But we also took another step and we assessed 50 of Kentucky parks and recreational areas. Are you wheelchair accessible? And we have a whole series of handouts of here's our assessment of that particular park. We wrote nice little write-ups on it, so when someone pulls it, they go, oh, I want to go over to Perryville, or I want to go over to Buckley. Here you go. This is what you can look forward to. Here's how you might have to adapt if you're going to go there. Some real practical steps on doing it. So these were all materials that were generated by our community partners, okay? And it's giving back to them. How are we building that into research? Well, there is a grant mechanism that just got turned out through Corey that is, how do you do patient-centered research? We've been doing that, so we're going after that funding to show them exactly how we can do it. We have a yearly meeting on, our last one was this past September. We held it at EKU this year, where we bring in national and internationally known experts in the area of spinal cord injury and stroke to talk to people about, okay, here's the current treatments, here is the current rehab. What makes these conferences a little bit different is who we have coming. We have healthcare providers of multiple disciplines, so it's not just doctors. We have doctors, PT, OT, speech language pathologies, nursing, social work. We also have community members coming in, and we have our people with spinal cord injury and stroke coming in. Everyone's listening to the same information at the same time and actually talking. Here's where you run into problems. I go to the National Neurotrauma meeting, and it's nerds talking to nerds about what people need. And I'm going, did you actually ask the people what they need? Well, why would you do that? Because they actually know what they need. So we average between 215 and 220 people attending these every year. And we're already starting to build the 5th annual one next year that we're going to incorporate brain injury, because we have a whole new study that is really getting fascinating on how little information is out there about TBI. Because TBI terrifies people. Because your loved one had literally changed many times. Okay? Ann Harrison over in PT and the PT students have developed this awesome website on falls prevention, and it's being used a lot by our community partners. Here are some practical information to prevent falls from the client point of view, as well as if you're a healthcare provider, here's how you can train somebody. Okay? And we like to sponsor some guest speakers to come in. Mark Wellman is internationally known para-athlete. We brought him in 2 years ago. He was over at Cardinal Hill. And to bump up the fun factor there, we also brought in the climbing wall, because he climbed El Capitan in that, and we set up the climbing wall right outside the spinal cord unit. And we got 8 people from the spinal cord unit go up that wall. Showing you what is possible. Your life has changed, it's not over. That is what we believe in heavily. Jennifer French is another, she is actually an Olympian, and she just competed in the Paralympics this past couple of months ago in sailing. So she is a wonderful speaker, but she also, like Dr. Repchevsky over in physiology, is got the implants, the E-stem implants that allow her to stand up. She trash talks Sasha pretty bad because she's got the upgraded versions. So she can do more than him. So, education, and when you think about education, education is at so many different levels. Education about your condition, but also what is possible. And that comes from my PT point of view, is everything's possible. The research we currently got going on is we are just finishing up a large study called the Needs Assessment for People with Stroke, the NAP study. Ann Harrison has led this particular one, looking at what are the particular needs of someone who's had a stroke. Because their needs are different than someone who's had a spinal cord injury. They're not the same. And what are some of the supports and barriers to that? So now that we know what we're working with and what we need, we can start to attack those issues in the community. And we have just launched our needs assessment for people with traumatic brain injury. Because the TBI population completely different than the other two. What are your needs? How do we support you in the community? And we launched what we call Research 101. Everyone can do it. And we designed 5 training modules that are now online. But the modules are how to do research. But it's not people in the college we're trying to train, it's how do we train community people to be part of research projects, and why is it important to them? And since we launched it, I do believe we're well over 200 hits of people viewing how do you do education. Because once again, we're a research network, or we are a community-based network that happens to do research. That's what defines us. But in order to do research in the community, I need the community to participate. So I need to train them, which we have been doing. But in order to get buy-in from them and to show them they can do it, we also launched our own pilot grant program. We kind of took what the CCTS does here at UK. Actually, our pilot grant came out before theirs. I say UK copied us. They probably aren't going to believe me. Where we tell our people, you come up with an idea, we'll help you turn it into a research project. We will fund it, and once you do the pilot study on there, we will help you take it to the next level. We're currently funding 3 grants. We have one group, which is some healthcare providers for ARH based out of Williamson, who are looking at the effectiveness of a post-stroke wellness program. Is it really effective to bring them in and do this outpatient kind of wellness programs with them? We are also funding a graduate student through UK to do some of her work in the stroke realm. And then I have one of my community partners who says, do you know what is the accessibility? Kentucky is known for all of their fall festivals. Are they wheelchair accessible? So Ryan is now assessing all of the different festivals to say, okay, are you wheelchair, are you handicap accessible? If not, can we partner with you so that you can become more accessible, so you can have participation from your community members? So a lot of this is how do we educate the community to get involvement. And it's actually this one, Research 101, that we're turning into a large 3-year grant through PCORI. And we're going to submit that next month, because this is showing that we can be successful. And another one of our partnerships between us, the Office of Vocational Rehab, and the Bluegrass Technology Center is what we call Project Carrot. Gotta love all the acronyms, right? Which is coordinating and assisting the reuse of assistive technology. When all's said and done, it means we have people donate durable medical goods, wheelchairs, walkers, canes. And we've had hospital beds and everything else. They donate them, we refurbish them, and we get them out to the people who can't afford them through our network. And that one has gone huge on us, and the state's wanting us to expand, and we're still staying in eastern Kentucky on there. But we're already getting in all of this equipment, we're cleaning it up. I'm using my PT students in Hazard because guess what, you need to know how to fix this stuff anyways. And I'm using it as a service learning component. But how do we just get equipment in and equipment out? Because the reality of Kentucky is we're one of the poorest states. And when you're talking about eastern Kentucky, you are talking definitely one of the poorest regions in the entire United States. And unfortunately, Owsley County got ranked #1. It is the poorest county in the entire United States. That's our reality. Not only are we rural, but we don't have any resources out there funding-wise. So how do we get equipment in and get it out to the people that we can? And we have a very extensive network that we're using now. And the first donation we got was 5 hospital beds, and it took us exactly 2 days to flip those and get them back out to the people who need them. We currently have the equivalent of 2 tractor trailers worth of equipment now that have already been donated that we have to get cleaned up and get back out. And we're not even trying yet. So, practical. But it was a research project that was funded through HRSA. So it's a federally funded grant for 3 years to prove that we can do it. Advocacy. We meet with local action groups. I don't call people on the phone. I get in my car and I drive out there and I actually shake hands and I have tuna fish sandwiches for lunch and I meet with people. They're not going to listen to someone on the phone. You get out there because when you go out to somebody and you meet with them, you show that you respect them enough to get in the car to come out. You do that, they're going to listen to you. So spent a lot of time meeting with local action groups and local officials, the Board of Chamber of Commerce, and a lot of local government I've spent 3 years talking with out there. We've had the opportunity to advocate for wheelchair accessibility. It was funny because Eastern Kentucky University, the Perkins Center is their nice, they updated their entire convention center there. It's across the street from the OT program. This is what OTs do, is accessibility. When we approached them last year to have our conference there, first thing we always look at was we look at bathrooms. Can't get a wheelchair in the bathroom, I'm not going to have a conference there because we're going to have people in wheelchairs. None of their bathrooms were wheelchair accessible. And we're going, are you kidding me? They ripped out their bathrooms for us. And they turned them into wheelchair accessible bathrooms for us to hold our conference. And don't want to be mean to my colleagues over at the CCTS, Center for Clinical Translational Science, but every year they have their big conference downtown. Well, they had my group and Sasha Repchevsky as speakers, first speakers in the morning. I got there early and they put us in a room and they put us on a nice platform. I go, you don't have a ramp to get up there. You do realize one of the speakers here is in a wheelchair, right? And they're going like, no! So even UK goofs up a little bit, so they had to completely switch all the rooms around for us because they go, even if you could get a ramp up to them, you put them behind a podium. Podium's that tall, well, Sasha in a wheelchair is about that tall. I said, nope, let's move it around. So they moved it around for us. So, and my poor students get mad at me because they go, we can't go into any place anymore without going, oh, is it wheelchair accessible? I go, no, I've ruined you. It's good. And that's what you should do, is like, okay, you go in there, can you get a wheelchair into any place? I mean, they're supposed to be able to. Everyone's supposed to be ADA compliant. The thing that people forget, ADA doesn't have much bite, and it's minimums. That's all it is. So that's why most places aren't wheelchair accessible. This is the one that we got ourselves into here. And this one is taking off on us. Next year, May 10th, 2013, we're going to have the inaugural Kentucky Congress on Spinal Cord Injury. Downtown, I've already rented a spot at the Civic Center. We're going to try to get 200 individuals in wheelchairs in the same room at the same time saying, this is what we want. And we're going to create a legislative agenda for this particular population. We have already got, I think at last count, we started last Friday, we already got 7 major sponsors for this saying, you got to do this. And we got places like Arkansas and Tennessee saying, wow, this has never been pulled off before. So if we can pull this one off, this has taken us to the ultimate conclusion. It's not only are we trying to help them, but are we doing the ultimate advocacy? And the ultimate advocacy is going to be working at the state level. Can we change laws? And that's what this is going to do next year. Invite me back this time next year to see if we actually pulled it off or not. And unfortunately, I get to do all the behind the scenes to say, okay, how do you fit 200 wheelchairs in one place? How do you have 200 people in wheelchairs go to the bathroom at the same time? That's stuff that I have to deal with. But here's advocacy at its ultimate conclusion. And we're going to try to pull it off because we're not smart enough to think that you can't do it. Most of what you find out when someone says it can't be done, I'm a firm believer in saying that you were too lazy to push it enough to make it happen. And we push hard. We push very, very hard. And I am blessed with all of the people in all those different organizations. I found the right person in each organization who thought just like me, who said, no is not a, you tell me no, I'll show you exactly how we're going to pull it off. Might be ugly, you might be kicking and screaming, but you're going to change for us. And the funny thing is, this is once again coming from a lab mole, who I hated talking to people. And talking with Jody, I wasn't a lab rat, I was a lab mole. It was one of those things, sunshine, ooh, sun bad, aren't good because you spent all of your life in a laboratory. To someone needs me to call somebody out in Eastern Kentucky, sure. Give them a call. What's the worst they can do? Say no? I've been told no before, and then we're going to go to the next person. And I'm going to say, oh, wow, they said no, you want to buy into it? Yeah. We can play the system a lot because everyone is doing it. We do a lot of sharing of information. We have monthly meetings. A lot of the PBRNs meet once a year. They have their big PBRN meeting. We meet every month. And we do it over ITV. So I got 4 different sites throughout Kentucky that we sit and we talk. And the buy-in to our community group is people aren't getting paid. And the first Tuesday of every month, I have got anywhere between 17 and 27 people online discussing stuff. That's proving that we're doing something for people because they're willing to take time out of their own schedules, they're not getting paid for it, to come in here and participate. Okay? If you go to our website, one of the things that we have done is we have a community resource link, and if you click on it, it's every county in Eastern Kentucky. You click on the county, it's every resource we've been able to find in that county. So instead of me sending you home to Breathitt County, and you go, oh man, who's going to do the rehab on my house? Who can I get food from? How can I get clothing? Because if I can't meet basic needs, it doesn't matter what I want to do rehab-wise. There's your reality. I don't want to have to call a number in Frankfurt and say, we'll get back to you on Monday. We have, here's who you're going to call in your community, and they're going to get it done now. That's what we want to be able to do, is I want to be able to say that we can cover every single need that you're going to have when you go back home. Okay? And we've done a lot of presentations. Anne's presented in Holland. I've presented at the PT throughout the nation here on this one because we are unique. And it's one where Kentucky, unfortunately, was always kind of, oh, you're from Kentucky, poor you. It's like, darn straight from Kentucky, we're showing you how you do it. So we're actually very, very proud that we're from Kentucky and we're pulling off some stuff that no one else has been able to do. Okay, and I've already talked about the quality of life one. Project Carrot is a big one. The grip solution, one of the things Lou did with our partner, Jason Jones is one of our great partners, and Jason is about a C4 paraplegic, so he can move his head. He's also a father of 2, which has been wonderful thing working with Jason, and he's the one who conned me into the Kentucky Congress idea. But when he had his newest son, all he wanted to do was be able to have his son next to him so he could see him, he could be close to him. But because Jason has to move back and forth, for pressure relief, he couldn't have anything right on his legs. Otherwise, it would cause some problems. So working with Lou, we developed a whole new lapboard system for him, and with this new material, Jason could move up and down in his wheelchair. Lapboard was stable. We could put the car top carrier for his son on his lap, and he could be next to his son. He could be the father that he wanted to be. Practical, low-tech, everything could be bought at Walmart. That's what we're all about here. And I don't even have time to get into no barriers, talk to Sasha about. There's a whole conference that is held every 2 years. Next year it's held out in Telluride, called the No Barriers Group. And it is a meeting of people of every imaginable disability coming together and showing that you could beat every barrier. And they do climbing, they do everything you could imagine out in the wild. And we've been sponsoring people from our community to go to that. And we're going to sponsor a few more people to say, okay, this is what's possible. And Sasha was laughing from the last one because everyone was comparing disabilities. They're going, oh, you're just a parrot, man. Suck it up. Oh, you're just blind. Pfft, whatever. Here, I got this, this, and this. They said the trash talk was just hysterical. And they just went multinational with the Global Explorers Group. And we're going to be sponsoring one of our community partners to go become an advocate for Global Explorers. Okay. We want to connect people with needs with community resources, and if we don't have community resources, we'll find a way to get it. But this only works if you're sustainable. The cool thing is every one of our partners has existed for a long period of time. They're companies, they're organizations, so we don't have to create them, they exist. We're just using their specific skill sets. So we don't have to build it, so we don't have to pay for it. And we are built on the most basic level of partnerships with the community. We're just using what's there and linking it. That's been the problem. So we existed before our NIH funding, and we fully plan on existing long after it's gone. However, we've actually been pretty good at securing funding for it. Which also tells you that stuff like this, the government thinks is important. And we have multiple grants that are going to go out next year. But yeah, we've been funded at multiple levels here for multiple projects here. And I'm getting on the grant writing machine again to fund things. I've never run into money. I've always been able to secure enough money to put on our yearly conference. Always. And next year won't be any different. Like I said, our big Congress one, we've already had sponsors said we want to partner with you, so we've already got our 7 sponsors for that one, and we didn't even try. So we can get the funding, and when you are developing into research, community-based research is becoming the hot topic, because for funding and for research, that's where research falls apart. It works great once again in a nice university. It works great in a hospital. It falls apart when you have to use it in the real world. So that's where NIH is sticking the money, big time, and other groups. So you got to move into that area. Because ultimately that's what we want to do as clinicians is I want my person back home and happy and taken care of. And here are all the wonderful people I work with. I get to sit up here and tell you about us. They're the ones that do a lot of the work and I get to work with. Any questions? Yes, ma'am.
Really, just a comment. Your comments about sustainability, I think, are so important. You know, funding agencies, yeah, used to be kind of looked at, yeah, they glance through that part of the grant, but that's more of a key issue. In addition, we've noticed when we've gone to Eastern Kentucky with a program, say fighting childhood obesity or something. Some of the communities that we've gone into, have been used to having a lot of grant money poured into them, and they allow that. So the first question is, how much are you gonna pay us? And we do see that once you leave, the program is not supported by the community. In fact, they get angry, you know,
Yeah.
where's the money? You know, and it's almost like a learned self-helplessness of a community. So I'm really glad you put that in there, because I think that's such an important part, you know.
It is, and we heard over and over again, is like, okay, you came in here, you started something, but it lasted 2 years and you were gone, and now we're starting all over again. So that's why we even took the step before that and just said, all right, this is what we gotta build here, and we're gonna build it so that all we're using is what we already have. We're not gonna rely on a ton of money coming in, and then trying to convince them that they had a lot to give. That was a lot. Most of them didn't realize exactly how much they had to offer and how much you can do with with a little amount of money. I mean, I can squeeze a nickel with the best of them. I can do a lot with a little. So that kind of mindset is like, okay, how can we pool our resources? And then when I go, did you know over in the town next to you, they have X, Y, and Z? And when we started to link groups together and they could see that they could do a lot with their little bit, they want to be involved, but they don't know how. So when we started linking them on projects and that, they're going, oh, this is possible now. Because we're going, you can't live and die by the grant. Just in this day and age, you can't. Because if you're lucky to get one big one, way to go. The chance that you get the follow-up on that one right away gets a little more difficult. So, yeah, we worked a lot. That bridge building was the first part. Before we even asked them for anything, we just talked. A lot of talking and got their input on how can we pull this off with it. But when you work with groups like the Lions Club, the Kiwanis Club, Rotary clubs, they're all service-based groups. They're supposed to do stuff. So I can use them. I just give them ideas to do. And there's a lot, especially in Eastern Kentucky, there's a lot of groups that come into Eastern Kentucky to help build. And they've contacted us saying, do you have anyone who needs ramps built or this? So we're already on their list. So as soon as summer rolls around, building season, we can get all the building we want done out there for our people. It's just getting in to know those people. We have one group that does building out of hazard, and I've also talked to a person who runs one of the labor to get boards and everything else. They said, we'll give you everything cheap or free if they'll allow us to come in and help. So we've found a lot of ways to do what people naturally want to do. It's just finding them and connecting them. Anything else? I'm sure this is not exactly what you thought you were going to come to.
Do you ever work with schools, like middle schools, high schools, that type
We want to, and we will. That is our next step. I mean, we are only 3 years old and have jumped beyond it. Ultimately, that's what we have to do. A lot of our people are going like, I was the only person in a wheelchair I ever knew going through high school. And unfortunately, the thing we run into, a lot of schools are in that clause area that they are what they are. They're not accessible. The moment they start to make something accessible, they have to change the entire school, and they can't afford it, so they choose not to. Which means they've just excluded people from being able to go to school. That's our next big one that we have to do, and we're hoping part of the Kentucky Congress on Spinal Cord Injury is going to hit some of that. And some of our people have worked with community colleges, and I want to start working with some of the community colleges because that might be our greatest way to start to get people back into education, because they can do online. It's not as big, so it's a lot easier for them to feel comfortable and get back into the scene, and then from the community college, move them back up into higher education. But one of our partners is Carly Perkins Vocational Training Center out in Prestonsburg, and they're an on-site training center for different vocations, and they have medical facilities there, so people with complex conditions can go there and get their training done. So we partnered with them right off the bat.
Do you ever go into like church-based?
That's our next, yes.
Because I know that's really important in those areas.
Yep. We have talked with them indirectly, but that is our next big push, and it's part of why another one of my mentors in this area happens to be Nancy Schoenberg. and their Faith Moves Mountains program. But yes, the faith-based community is actually an essential one for us to start to get into, and we've kind of hit it roundabout, but not, we haven't had the resources to really pursue that as much as we want, and that is what we're going to be going this next year for. But you're very, very correct. Anyone else?
Dr. Kitzman, thank you
Thank you
so
very
much
much.
for coming and sharing